Did not. All right, I'm starting the recording now, okay? I have to manually start it. My apologies. You'll get it from here, which is, fortunately, is the beginning. There we go. Sometimes I have no brain in my head whatsoever. All right, good. All right, so we've created a society that honors the servant but has forgotten the gift. And what I want you to know about this is that we go on the evidence-based model. Guess what? We have to use other factors because the evidence-based model doesn't work. Okay, so I want you guys to be clinicians. And what I mean by that is I want you in equal measure to use science, clinical acumen, and intuition. The best detectives and the best doctors in the world use intuition. Okay, if anybody's read Sherlock Holmes, you know that he would let things slip into place after a little while. Okay, if anybody's watched Dr. House, about 45 minutes into every episode, he does this. And the reason that he does do that is he's letting all this stuff sit together. And any of you who are mothers will know that when you have to make a decision for your child, and it's a serious one, that you get very quiet and you listen to that little voice inside of you, not the screaming and the yelling and the jumping up and down, but the little voice inside of you, and that's intuition. Okay, so guess what? Your intuitive sense is just as important as your clinical acumen, which is just as important as the research that's out there. Okay, I want you to be clinicians. So I also want you to treat the patient, not the test. For those of you who do testing, tests only test what they test for. Okay, so guess what? They're not as accurate as you think. You have to interpret them. Not read the test, you have to interpret the test. So you get things like this. Good news, your lab results are great, everything is normal, you're the picture of health. Nonsense. Look at that patient. Okay, so what I'm going to do today, we're going to do this very, very fast. Like I said, you're getting a recording and everything else. We're going to talk a little bit about autoimmunity and how it relates to all chronic diseases. What is the single source of all chronic diseases? What the contribution of epigenetics are, what the downstream effect analysis is, the contribution of breast implant illness, and we're going to do a couple of case studies. Hopefully we have time, okay, to get them all done. But hopefully it'll pull everything together for you. So, ready? Seatbelts on, you're going to need it. All right, autoimmunity. Listen, I'm going to make this very, very simple. Autoimmunity, if you look it up anywhere, just says the immune system is not working. And I say, thank you, Captain Obvious, okay? Because they don't really know why. And they talk about all these different factors, genetic predisposition, but they don't know why the immune system does not recognize self from non-self. That's self, that's non-self, okay? And we don't really know the reasons. We know that the body will look at markers of self as being various antigens, like the human leukocyte antigen, major histocompatibility complexes, and so forth. And we also know that when pathogens attack our cells, it changes the antigens on the cell walls, and they will go, our immune system will go after an infected cell based on that. But they still haven't told us why it doesn't work. Okay? So we know that we have the classic immune system, which is the older, or the using anatomic barriers, inflammation, the complement system, using various cells. This is our innate immune system. So when things stimulated, we attack. Okay? But it's usually when it's a pathogen, it goes through something called the antigen-presenting cell. I want you to think of this as a maitre d', okay? And I'll use the leaky gut syndrome as an example, okay? Mind you, I give pictures because I'm hoping you'll pick some of this stuff up, and this is the way you explain it to your patients. When you explain it to your patients this way, what happens? You empower them. When they know what's wrong, and they know how they're supposed to heal, and you do it in a manner that they understand it, they will heal. Okay, when you give them all, and this is what most doctors, they give them all these fancy explanations and they use polysyllabic terms which only impress themselves, and the patient walks out of this saying, hey, that doctor really knows what he's doing. What did he say? Have no idea. Didn't understand a word he said. Okay, that's not being a physician. That's not being a good healthcare provider. Okay, so let's use leaky gut. The leaky gut has a mucus layer. The purpose of the mucus layer is to trap all the antigens, toxins, and what I like to call the bad boys. and then secretory IgA binds it up, right? Okay, so now you also have the layer with all the fingers, all right? Those cells are held together by tight junctions. When one of those cells becomes injured by the aforementioned bad boys, what happens is they release cytokines. Those cytokines go out, and very much like the extraterrestrial ET, okay, they will follow the cytokines back to the area of damage and start cleaning up the area, which means they tear the cell apart. So we're always worried about these tight junctions. Tight junctions, don't worry about it, because what's happening is the cell's dying, so the tight junction separates. Okay, you can throw as much zinc carnosine as you want in there. It's not going to, seal up the tight junction. You've got to fix the cells. Okay, so when that opens up, and we have a lot of them, those antigens can get into the basement membrane, which is called the lamina propria, and macrophages will start chewing on them. They become antigen-presenting cells. Okay, literally like a maitre d'. Okay, they take their products, bring it over to a naive T cell, which decides under cytokine control whether it goes through the Th1 pathway to create a killer cell or the Th2 pathway to create an antibody. And in each one of those pathways, it takes a little bit of time for it to happen the first time, but they develop memory cells, which allow the reaction to happen quicker. Therein lies the problem. Okay, so our adaptive immune system uses specific antigens to strategically mount an immune response. So we develop these we develop the immune response based on the pathogenic antigens, and this is an example of B cell activation, which creates plasma cells, which creates antibodies. Okay, this is an example of T cell activation, which is more going after cellular invaders. Okay, and these are the CD4 T cell subsets. Okay, so if you really wanted to test this out, sometimes you can get a little bit of indicator based on whether it's a Treg cell, Th1, Th2, Th17, what it's going after. Okay, but these tests get a little nutty after a while. Okay, you can just start complaining, you can start really explaining all this stuff and putting in the genetic polymorphisms, and you can show their patient something like this, and they have no idea what you're talking about. Absolutely no idea. So I believe in Albert Einstein, who said, if you can't explain this to a 6-year-old, you don't understand it yourself. And immunity is tough. So often I will take the system and break it down to its really good parts, okay, and say, okay, this is how it works, and this is how I teach kids. And everybody remembers Mr. T from the A-Team. So let's face it, there is a Mr. T cell. And Mr. T gonna pity the fool who expresses a non-self antigen. And he gotta help herself because Mr. T wears glasses. And we don't want him to miss who the enemy is. So the helper cell concept brings him along, kind of shows him the enemy. It's also a guy who creates the memory cells just to keep down the sentinels, just in case some of the bad guys come back. But there's also a T suppressor cell, which is what we call a T regulatory cell, but a T suppressor cell because sometimes Mr. T gets a little upset and he needs somebody to take him out for a drink, take him out for dinner, just calm him down. So the way your body works, you got the Mr. T cell going to protect you from any invaders. He pity the fool expressing non-self antigen. And he's got a T helper cell going to give him a hand, and he's got a T suppressor cell in case it gets a little bit too excited. I'll tell you something, in 3 minutes, second graders understand the T system. And I've seen them, their mommies come to me and sometimes say, well, what is this Mr. T thing? Because a child would get sick, and they say, don't worry about it, Mom, Mr. T's going to get him. Mr. T going to get him, okay? What does it take away when you empower your patients? It takes away fear. When you take away fear, now you allow them to heal. I'm not going to go into a religious construct, but that's the way it works. So autoimmunity, what do you have to know about autoimmunity? It gives you signs of inflammation, okay? And you're going to find out that most of the autoimmune constructs out there have inflammatory symptoms as their base. So whether it's Graves, Hashimoto's, SLE, type 1 diabetes, MS, rheumatoid arthritis, IBD, IBS, Addison's, psoriatic arthritis, yes, there's some differences, but they also have fatigue, aching muscles, swelling and redness, trouble concentrating, numbness, tingling, hair loss, they have a whole mess of different things, okay? It's all based on the chronic inflammatory response syndrome, which is inflammation. Now you see chronic inflammatory response syndrome usually based on a biotoxin exposure, but it's any kind of exposure, okay? And the word is chronic. This has been so ubiquitous that it has caused a rise in health issues over the years, including cardiovascular issues, GI issues, diabetes, metabolic disorders, adrenal fatigue. And these are inflammatory problems. Okay, you want to reverse atherosclerosis, you want to reverse Alzheimer's, get rid of the inflammation. But it usually attacks the nervous system, causing all manner of different symptoms based on genetic predispositions that is being expressed. So you know that body-wide inflammation can cause changes, let's say in normal blood flow, that will cause aneurysms. They will cause the blood flow to start eddying, and when they start eddying, when it slows down, it starts clotting. That's one of the ways you get clots. And we're all aware of the diabetic complications, and these are all inflammatory related and the results of inflammation. If you get a chance, get this particular poster from livelovefruit.com. I love this poster because it, in a very short picture, it will show every part of the body and what inflammation does. So brain is pro-inflammatory cytokines cause autoimmune reactions in the brain, which can lead to depression, autism, poor memory, Alzheimer's disease, and MS. Let's say the thyroid. Autoimmunity in the thyroid can result of inflammation, can reduce total thyroid receptor count and disrupt the thyroid hormonal function. This is made for patients, and if you make it clear to them that the problem is chronic inflammation, and then go into what the causation, which can do about it, okay, they can see themselves here, and they're going to be cooperative and compliant with your treatment plans. So I'm going to dip down because sometimes we all forget the importance of the cell. Everything happens in the cell. The cell is the foundation of life. Everything, methylation, glucuronidation, bioapterin, tricyclic acid cycle, liver phase 1, phase 2, everything happens within the cell, mitochondrial function, okay? And the maintenance of the cell wall is one of the most important things you can do for a cell. The fact is, if your cells aren't working, nothing will work, okay? So we tend to think of things in different parts of the body, but we have to remember cellular physiology because that's the way to heal somebody. And what a cell does is create energy, then manage waste. Simple, right? But always remember, the garbage men, the trash men, are the ones who get the energy last. So have you ever wondered if there's a common ground to illness? Why do some of your patients remain ill despite treatments that get others well? Sometimes, I know I feel that. So do you feel like you're guessing or you're treating the wrong thing? So I came up with this thing. I said, maybe we're treating the wrong premise. And then I did a little chart one day, and I correlated chronic Lyme fibromyalgia, ME, and dysautonomia, and found out basically they had the same symptoms, maybe the same causation. This is about when the cell dangerous response paper came out. Now, when you read this paper, don't go crazy. Piece by piece, you read it, you read it again, you read it again, you read it again, you're going to pick up more things. Bottom line is what I'm going to show you. This is, by the way, this is the actual paper. If you typed in Google cell danger response, you will get the paper. It's everywhere. It's the metabolic disease features of the cell danger response. It is written by Robert Navio, MD, PhD, who is at the Metabolic and Mitochondrial Disease Center at the University of Southern California Medical Schools. Okay, he is an incredibly smart man. I've met him. Okay, but what is the cell danger response? It's the metabolic response of the cell to protect itself and thereby you from harm, and the way you reestablish homeostasis. Simple, right? That's why I got the bear there protecting the wolf. So it kind of I'll type out the mismatch in a second. What activates the cell danger response? Okay, what activates it? And by the way, this is mine. Yeah, it took me about a couple hours to find that cell. I typed in sad cell and I saw this little guy. I said, aha. All right, so things you really already know about. Things that can damage a cell, heavy metals, BPA, benzene, yada, yada, okay? Microbes, mold, fungi, parasites, bacteria. And what we tend to fob off as being a lesser thing are all the psychological damage, okay, from non-nurturing childhood, from yelling, abuse, isolation, abandonment, PTSD. It doesn't have to be just the rape or the battle although those are horrible, it can also, if you listen to your patient's histories, okay, be this non-nurturing type childhood with an overbearing parent. A lot of times it goes back a couple of generations where the mom was abused and then she overprotects her child. This can go into very serious pathology. But remember, listen for those things. Listen for trauma in childhood, okay, because that will start a process that, unless you intervene, simply won't go away on its own. So the CDR, cell danger response, I'm just going to call it CDR henceforth, is a cascade of events. So when the damage happens, when the insult happens, there's temporary impediments in cellular electron flow, mitochondrial function, oxygen consumption, which is necessary for Krebs, cellular fluidity, cell wall integrity, vitamin availability. Okay, you ever meet somebody who takes vitamins and they're doing good, but as soon as they stop taking the vitamins within a week, they're rubbish? Okay, there's a reason for it. And metal homeostasis, which is the cell's ability to get rid of the metals that are in the air. Redox, lipid dynamics, creation proteins, bioenergetics, protein folding and aggregation. Well, here's what happened. Normally, if it's a single event, we have anti-inflammatory pathways and regenerative pathways that will be used to reverse CDR and promote healing. That, if it's a single event, it's cool, right? But when it's chronic or multiple, the interference with the allostatic / homeostatic mechanisms don't just add up, they synergize. So there's not only numerous downstream effects, but those homeostatic mechanisms that I just mentioned become chronically impaired. I won't say permanent because nothing's permanent. They become chronically impaired. And the takeaway here is that once you get to that point, the cell will not reboot itself without intervention. And that creates the root of all evil. Money, right? Actually, that's in the wrong spot. Inflammation. Okay, all these things create inflammation. And I think this is where people get tripped up. The usual medical premise, and unfortunately from a lot of our naturopathic people, and I do mean that in the wider sense, the premise is eradicate the root cause and the body will heal itself. That is a problem because you know from your clinical experience that there's a ton of people out there with chronic illnesses who are not getting better. So if we use this premise, what happens? It results in chronic conditions, confusion as to why the condition won't heal. It'll also start the process of the patient blaming themselves, or being blamed for being histrionic, symptom magnification, malingering, and then their families not supporting them, and them really questioning whether it's in their head or not. And the unfortunate conclusion that certain diseases cannot be cured. The common wisdom about Lyme disease presently is that it cannot be cured. So the advanced practitioners treatment, you guys, your premise is there are root causes and downstream effects. They both must be identified and treated. In chronic conditions, the homeostatic mechanisms won't reboot without intervention. And both foundational treatment to treat the cells and treat the body and targeted root cause treatment are administered. And that's how you're successful, by working at both ends at once. And very interesting, Dr. Navia just released another paper about 4 weeks ago, which I have not been able to go through because it's that complex. But I noticed on the first page something very, very interesting, where he says, and the paper is right there, you can get it off the internet, that much of modern Western medicine is based on the principles of acute interventions. And these interventions are an important part of good medical care. However, in dealing with the chronic illness, treatments based on the rules of acute care medicine have proven less helpful and can even cause harm by producing unwanted side effects. For an MD, PhD to say that, even that mild manner is kind of telling his colleagues, you haven't got it. You haven't got it. So what are we really talking about? We're talking about CDR. We're talking about reactive oxygen species. Okay? The reaction oxygen species can be things like free radicals, reactive nitrogen species, and oxidative stress. So when you think about this, I want you to always be careful that when you're talking about ROSs, that you're not really talking about RUSs, which are rodents of unusual size. That usually gets a laugh, but I realize you can't laugh. Okay. I'm going to go to, remember that what a free radical is a atom that needs electrons in its outer shell, because when it's like that, it is in a reactive state, and we would say a disharmonious state. Okay, because in quantum mechanics, if you have the electron shells filled, okay, it's using a lot of less energy, and it's in a less reactive and, if you will, more harmonious state, you know? And you can't do this, I mean, the atom doesn't do this, okay, when the energy is in a higher state, or in a higher shell that's not satisfied, or it doesn't have a partner or anything, it's in a more excitable or more reactive state, okay? So, here's the thing. In quantum mechanics, what ends up happening, and you know this from your basic chemistries, that when you get these larger molecules, what ends up going on is that they share, okay? And whether it's polar or nonpolar, they actually share. So this compromise, which is also known as Heisenberg compromise, okay, is actually creating stability for both atoms. And the more sharing that occurs, the more stability happens, and the more stable the molecule now is, the harder it is to break apart. So that's sort of like our relationships and so forth. There's very few people who are hermits, like the halogens, that just like being where they are. But most of us have to share, and we have to create a harmonious relationship, or a harmonious lifestyle. So it shouldn't surprise you that what goes on in our quantum level is what we reflect in our outer world, okay? So really, when you think about reactive oxygen species, okay, it's really an unpaired molecule in a high excitatory state looking for trouble. And you can read this, you know, the whole thing about oxidative stress, I want to tell you, is not the fact that you can understand all the blessed things about oxidative stress. And what do? We give antioxidants, right? Oh, antioxidants. Thank you. Antioxidants, that scarfs them up. But if you don't get at the cause of it, the oxidative stress will continue. And that's the biggest problem. You know, people say, well, you use that, it's a Band-Aid. There's nothing wrong with a Band-Aid. The dishonor occurs with a Band-Aid when all you do is use a Band-Aid. That's it. Okay, if you don't look for the reason for bleeding. So different things will cause inflammation. Inflammation is oxidative stress. So increased oxidation will reduce mitochondrial function, which is where all of our healing takes place from the mitochondria, right? Okay, in this way. I'm going to show you something interesting about glutathione and mitochondrial function. The particular study is right there from the Journal of Amino Acids in 2012. This is from the pathway planner from Dr. Ben Lynch. When you get to the point where you have homocysteine, which will be above CBS, after the methionine pathway, CBS turns homocysteine into cystathione, and then it creates cysteine, and then you work your way down to you pass GCLC and then GSS, and then you get active glutathione. Where that inflammation arrow is pointing, things that are in purple here will slow down the enzymatic reaction. TGF-beta-1, mycotoxins, HIV, alcohol, uremia, in other words, inflammation, inflammatory products, infections, and so forth. When you get to the point where you have created glutathione, here's what happens. Glutathione, when it's used up, and because it's your master antioxidant, when it's used up, it will create GSSG, which is oxidized glutathione, okay? And all that is, God, spirit, or whatever you like to call it, okay, because God really doesn't matter, just get those items. That glutathione, oxidized glutathione, will, in fact, be recycled back to active glutathione. But it requires this pathway, okay, and all these different genes, all these different enzymes. And it's basically an NAD-dependent pathway. So what happens if this is not working well and you have a large amount of oxidized glutathione? Well, this is what happens. All right, the large amount of oxidized glutathione will actually block the entry of the electron donors into the first complex of the mitochondria. So a while ago, we discovered that we could test the mitochondria from now until forever, but our interventions weren't doing so hot. And I know Dr. Myhill has done wonderful work on this. I greatly respect her. I have no idea, but if the cell walls are not patent, where are these protons going to go? Okay, and if we have too much oxidized glutathione, kind of doesn't matter how much coenzyme Q10 and everything else we have, this is not going to work. By the way, the reason that the ketogenic diets work in this particular stead is because their products enter in complex 2. So chronic cell danger response is responsible for all these different conditions and a lot more. Okay, you know, traumatic brain injury, bipolar disease, autism, heart disease, cancer. It's all based within the cell danger response. And if you understand how that works, that's the base of all illness. That's just the base of all illness. That's not causations. Okay, it's the base. It creates this arguments about oxidative stress and oxidative shielding. Don't worry about it. Okay, the fact is you've got root cause, downstream effects, and the downstream effects are created and maintained by the cell danger response. Okay, this is the new paper that's out. Okay, he divides CDR into 1, 2, and 3. CDR1 is the most serious stuff. CDR3 is the easier stuff to fix. Like autism, chronic fatigue, post-traumatic stress, fibromyalgia, all this good stuff. Okay, believe it or not, it's very easy to fix. Whereas things like systemic inflammatory response syndrome, which is death, you know, multiple organ dysfunction syndrome is really, really tough. Okay, I wouldn't want to lie to you. You know, the nice thing about studying this stuff is sometimes you come across something that you can actually intervene with a patient. Okay, and this is going to take more time. So what else is cell danger response do? It can affect the genetic polymorphisms, okay? And God forbid I shouldn't talk about genetic polymorphisms. And I know that we're all methylation crazy. So guess what, guys? These are all the biochemical pathways in the body, okay? And you will notice that there is a blue line. That's where methylation is. So if you run into a methylation practitioner, give me his or her address, and I will be visiting them. Because you can't treat a single pathway, you can treat the whole body. Remember, you can understand things very minutely, but you cannot treat. Okay? You cannot treat the body minutely. You can only treat globally. Okay, so when you talk about polymorphisms or SNPs, I just want to tell you what they mean. They're an estimate of the enzyme's functions without anything else going on. So if you see green, it's normal, it's the usual underlying function. It's like an 8-lane highway. If it's heterozygous, and that's about 60% enzyme function, think of a 4-lane highway. If it's homozygous, I want you to think about a 10 or 20% enzyme function, which is sort of like a 2-lane highway. Do the number of lanes in the pathway really matter if there's no traffic? Of course not. But when you start throwing traffic in, the 2-lane highway is going to block up quicker than the 4-lane. Okay, and that traffic can be bacteria, heavy metals, viruses, parasites, or a combination thereof. When you have a lot of traffic, you won't get the pathway, you won't get what the pathway is trying to provide you. You'll get it slower, but you're not turning on or turning off genes, okay? But people think of it like that. And I also want you to know that just because it's green doesn't mean you're good to go. Because you'd think you could put enough traffic in those pathways to slow an 8-lane highway down, you think? So for those of you who know Dr. Ben Lynch's strategy, okay, the purpose of strategy was to take the polymorphisms and place them within the pathways for one conclusion and one conclusion only, that you could look at the pathway and say, that pathway might have difficulty under oxidative stress. So you'll look at the gene and enzyme, you'll see the purple, or the factors that would decrease the activity of that enzyme, orange, which would increase the activity of the enzyme, and what the cofactors are that you need for the enzymatic function. This is a folate pathway. This is my folate pathway. Okay, and they're very easy. Folates are, this is reduced folates. Okay, this is the pathway that brings them to 5,10-methylene tetrahydrofolate, which is the stage before it becomes 5-methylfolate. And you can see that if you go down here, all the curved lines have NAD, NAD, NAD. This is an NAD-dependent pathway. And think, whoop, and what will slow this down is folic acid, green tea, grapefruit seed extract, methotrexate, sulfur, okay, dairy antibodies, and the like. Okay, now, when you get down to, this is MTHFS, methylene tetrahydrofolate synthase. When you get to 5,10-methylene tetrahydrofolate, it passes by the dreaded MTHFR. And I think I'm talking about the dread Pirate Roberts a lot of times. And the reason I say it like that is because too much concentration has gone on to this one enzyme. MTHFR does one thing and one thing only. It turns 5,10-methylene tetrahydrofolate into 5-methyl tetrahydrofolate, or the active 5-methylfolate. Same thing. It needs B2 and B3 to work, and things like SAMe, cell danger responses, reactive oxygen species, dihydrofolate, and sulfur will slow it down. Now, I ask you, why would dihydrofolate slow it down since it's being produced up here? This is a negative feedback. So if too much dihydrofolate is being produced, it slows it down there. This is my biopterin pathway, okay? And if you look at tyrosine going to L-dopa, then to dopamine, and really DBH should be red here in me, but it's not in strategy, it's in another report. So you can see that COMT, MAO have difficulties, so the degradation of dopamine is going to be interfered, giving you a net high dopamine. And what we're usually measuring is HVA or VMA, HVA being the degradation product of dopamine, which needs FAD, NAD, B1, and SAMe to happen. And if you could look at all the different things you need to get down to VMA, you can realize that if you have a low HVA or VMA, either you may have low catecholamines or not enough cofactors. So you have to make decisions. On the other hand, when you're usually measuring on the organic acid test, let's say 5-HIAA, 5-hydroxyacetic acid, okay, that's downstream of serotonin. So tryptophan turns into 5-hydroxytryptophan, which becomes serotonin, which hopefully becomes melatonin. But if it goes down this degradation pathway, this is what you're going to get. Now, if this is low, you can make the assumption that serotonin is low. You got to ask yourself why. If we go back to where tryptophan is, you see another line. These oranges is what upregulate the enzyme. So things like stress, lipopolysaccharides, pro-inflammatory cytokines, in other words, inflammation and stress, will make this enzyme work quicker, and then it's going to look for substrate, and it's actually going to pull tryptophan out of the pathway. And that's called tryptophan steal. Where'd it go? And that will create chirenic and then eventually quinolinic acid, which is an excitotoxin. So a person whose excitation, which can be expressed as a whole mess of different things, a person who has excitation, and it's because, you know, they have bugs or whatever, and their dopamine remains high, they're going to need serotonin and GABA to counterbalance it. But the very same reason why they have low serotonin is because of the infection. So if you see the pattern of high catecholamines and low serotonin, one of the reasons is because of infections, which is being kept going by the cell danger response. This is my transsulfuration pathway, and my conclusion for myself is I might have difficulty in recycling. There's something else here that's going to be a real gift for you, and this is from Susie Cohen, Susie Cohen, who's America's most trusted pharmacist. She put together what she called medication-induced SNPs. She put the pathways in very briefly, and then showed all the different medicines that can affect the pathways. And let me tell you something, you should be asking about medicines, but this can help you out when something's just not going right and you find out they're on a particular medicine that's blocking a particular area. Okay, and here's transsulfuration and holds the various medicines that affect it at different parts. And here is biopterin doing the same thing. Statins are nasty people, by the way. Okay, so neurotransmitter balance. Hopefully everybody's alive out there. Okay, let's see what the time is. Okay, we're cranking. All right. This is again. I have a lot of nicknames. One of them is a neurotransmitter whisperer, and this is how I think about neurotransmitters. Okay, I created something called the brain wall, which will help you understand the different parts of the brain, how they act, what conditions live in there, and what neurotransmitters are primary. So let's talk a little bit about neurotransmitters. Epinephrine, norepinephrine come out of the adrenal medulla. If they're too high, you're going to have irritability, anxiety, and so forth. Too low, you're going to have low energy, low focus. That kind of makes sense, doesn't it? Okay, dopamine is your neurotransmitter of satiety. And when it's low, you can get something called anhedonia, which is a lack of joy. This is a different kind of depression that you'd expect from serotonin. This is the black depression, the bipolar depression. And the way you tell is because you can ask your patient, do the things that used to make you happy don't make you happy anymore? That's a really low depression. Okay, when it gets really low, you can think Parkinson's. But when dopamine is high, okay, you start thinking about paranoia, irritability, psychosis, and very high ADD. I'm sorry, ASD, autism. Remember, dopamine being your neurotransmitter of satiety. Okay, this is when you have a good event and you're totally satisfied. If you look up reward deficiency syndrome, you're going to see a lot of work by Kenneth Blum, PhD, on the DRD2 receptor, which controls the dopaminergic system, or your ability to achieve satiety. It's one of the major reasons for addictions. Inhibitory neurotransmitters, we're used to serotonin. Okay, low serotonin will give us anxiety, insomnia, depression, and usually a craving for carbohydrates, not sugars, but carbohydrates. So chips, potatoes, and stuff. So if you ever want to read a book, it's called Potatoes for Prozac. It also gives you headaches and unexplained gastrointestinal symptoms. Well, the unexplained gastrointestinal symptoms come from the fact that that serotonin is the major neurotransmitter of the enteric nervous system. Okay, serotonin syndrome you're almost never going to see, and don't ever believe those people that say if you take an SSRI you can get serotonin syndrome if you take 5-HTP. That's complete nonsense. Okay, so here's the cool thing. Here's the prefrontal cortex, which is in the front of the brain. Everything's color-coded. Okay, the function of the prefrontal cortex is attention, judgment, impulse control, empathy, and so forth. It grows until age 25, and ADD lives here. So dysfunction is distractibility, impulsivity, poor judgment, laziness, tardiness, lack of forethought, and everything that one calls a teenager. And that's why teenagers act stupid. Why did you do that? I don't know. They really don't. Dopamine, epinephrine, norepinephrine are the major guys here. The anterior cingulate is where OCD and ODD live, oppositional defiance disorder. And this is your stubbornness. This is where people with obsessions and compulsions come in. People who are oppositional, and serotonin is the guy who runs this. The basal ganglia is where anxiety lives. And there's left and right basal ganglia dysfunction. When it's right, they internalize their anxiety, suicidal thinking, self-mutilation. But when it's external, this is when they're verbally anxious, yelling, screaming, homicidal thinking. Okay, this is where anxiety, like I said, lives. This is where you get your tense shoulders, and GABA, gamma-aminobutyric acid, is what helps run this. On the subject of gamma-aminobutyric acid, it is the chief inhibitory neurotransmitter in the mammalian nervous system. We produce it when you produce glutamate, and it goes past the GAD enzyme, which is glutamate carboxylase, and produces GABA. And there's usually a lot of problems in that area. So we are trying to, a lot of times, create GABA, and things that will give you GABA are alcohol. It doesn't really give you GABA. It stimulates the GABA-A receptor, and the GABA-A receptor releases GABA, okay? And benzodiazepines will do Xanax, Klonopin, and so forth. Guess what? These only pop on here for a short period of time, okay? And then you need more, and that's where the addictive quality comes. There are some other substances out there that you can use that will be a whole lot better. There's a phenylated GABA. I know that that's a phenobute, and it's probably outlawed here in England. And that's because they were doing the studies on a beta-phenyl gamma aminobutyric molecule, which gave an awful lot of problems. But there's another molecule called the 4-amino-3-phenobutyric, and that is sold as Cabanase or phenotropic. And I've used it for decades and I've had no problems with it. And what it does is give the brain GABA. And it doesn't stimulate the receptors, it simply gives the brain GABA. The other thing you can get your hands on here is a liposomal GABA with L-theanine from Quicksilver Scientific. If you go to Quicksilver Scientific's website, they'll give you the international distributors. This is a liquid that you can spray in the mouth, and the GABA gets into the brain in about 5 minutes. Yes, it's a Band-Aid, but if you have somebody who's incredibly anxious, or a kid with ADD, or a kid with autism that's just absolutely wild, it's really helpful if you can calm them down, okay, and counterbalance some of that excitation. It's very, very, very helpful to them because they're using an awful lot of energy, and it's very helpful to the family too. You're not snowing them, these things have no side effects. Depression lives in the thalamic limbic system, which is right above the cribriform plate in right where your nose is. Okay, this is your emotional filter. This is what tags your interior importance. This is how you evaluate your emotions. This is where your libido lives. And this is why when you smell different substances, you can recreate emotional states. Okay, but depressions, decreased sex drive, social isolation, increased, negative thinking, also sits here, and serotonin is the guy who runs it. The temporal lobe on the left-hand side is mostly processing language, short-term memory. The right side is more facial recognition. And the point that I want to make here is that when there's left-sided dysfunction, there's a lot of aggression, fighting, sensitive dislikes, and so forth. And honestly, the reason that children who've been abused become abusers themselves, aside from all the psychological stuff, is that most abusers are right-handed. And when they're slapping kids upside the head, they're usually slapping them on the left-hand side. And you do that enough, you're going to create left temporal lobe dysfunction. The other concept I want to impart to you today is the concept of neuroimmunology. Now, the neurological system puts out neurotransmitters as their biomarkers, okay? So they obviously have receptors for that. The endocrine system puts out hormones as their biomarkers, so they have receptors for that. The immune system puts out their biomarkers, and those are chemokines and cytokines, and they have the receptors for that. But in this super system, each of these areas have the receptors for everybody else's biomarkers. So they're constantly talking to one another. So if you have an immune problem, like your gut syndrome or immune yada yada, it's going to affect the hormones and the neurotransmitters. If you have a hormonal problem, it's going to affect the other two. That is from one point of view. From the other point of view is when you have somebody who has a really complex multifactorial case, sometimes you can fix them from the hormonal angle, sometimes you can fix them from the neurotransmitter angle, and sometimes you always need to treat them from the inflammatory angle. Here's some references for you. Dynamic neurotransmitter assessment, I'm going to go through this very quickly if you're going to do this. These patterns, the 20 to 80% that you see from top to bottom, are the normals. When you see a pattern like this is a recent infection, whether it's viral, bacterial, or whatever. But the neurotransmitters will drop over time. So what I did was I put together a chart, and if you look up the upper left-hand side, you see everything's basically high. Look on the upper right, about a year later, the norepinephrine, epinephrine have a pattern of one up, one down that is still in the very high range. But that's the first stage of adrenal fatigue. You go a couple of years later, you see that epinephrine, norepinephrine pattern is still there, but now the epinephrine's in the lower part and the norepinephrine's in the normal range. And now you're starting to lose your inhibitory response. Things get worse and worse and worse until you get somebody who had Lyme for about 15, 20 years, and all the findings are low, but the inhibitory neurotransmitters are far below the excitatory, so this person is wired but tired. Okay, this is how you can look at something and say, that's an immune problem with advanced decompensation. And once you've read these things a few times, it becomes rather easy. I know you've been taking histories, but I'm going to smack you upside the head about histories because it's that important. You have to remember that what doesn't happen in allopathic medicine any longer is the fact that no one listens. Okay, it's been shunted so that the doctor has minimal time with the patient. You walk into the doctor's office, you fill out a history form there, you hand it to somebody, no one even looks at it, okay, and then they get to the chief complaint and no one knows what's going on. And listen to your patient, he's telling you the diagnosis was said by Sir William Osler, who's the founding father of Johns Hopkins Medical Center, and he said that in 1895. So always remember, in real estate, it's location, location, location. And in healthcare, it's history, history, history. You want to be the master clinician? Learn to listen. So before you start, and I say this from my heart to your heart, you have got to ask yourself, am I willing to work in shades of gray? You are not going to get anything. There is nothing that points from one thing to another. There it is. I don't care what the testing companies say. I don't care what the algorithms are. It doesn't work that way, okay? Because there's no such thing as a scientific certainty. Remember, when research is performed, the researchers will cut out as many variables as possible. As clinicians, we have to take that information and apply it to a human being that has innumerable variables. So you have to be comfortable in shades of gray. That's why the researchers don't like me anymore. Because I start applying it, I'm like, well, why'd you do that for? What'd you do this for? I'm like, because it works. You know, but I said, listen, you cut it all out, and they get very snooty. So they don't invite me to their parties anymore. I just tear them apart a lot. Okay, so remember, the other thing I've been seeing here in England is that the naturopathic physician, the naturalist, the nutritionist, already feels ostracized, already has everybody from on high looking down their nose at you. Let me tell you a little secret. It doesn't matter how many courses you've taken, how many degrees you have, how much you know. If you can't put the pieces together, it's all for naught. And I'm going to tell you right now that our medical colleagues are not putting the pieces together. You know why? Because they're specialists. And when you're a specialist and you become a subspecialist, you are concerned with your area of specialty, and that's it. You don't coordinate with anybody, and then when somebody comes that has a strange condition, you go right to the either referring them out or it must be you. So I charge you all with stopping the thought of being a specialist and starting the thought of being a generalist. The generalist knows everything, is willing to coordinate care, willing to advocate for patients, and yes, sometimes has to eat a lot of crow, okay, and take a lot of heat. But you'll be the person putting the puzzle pieces together, and you'll get that reputation. And guess what? You're the people who are going to do the healing. And I have complete faith in you. So when you're doing history, look for, take a timeline. Okay, look for a baseline. Look for temporal relationships, deviations from the baseline. Ascertain the reasons for the deviation. Look for downstream effects. And never, ever, ever say or even think that can't happen. I promise you, if you even think it, I will show up on your doorstep. If you say that can't happen, what happens? You cut out a complete avenue of communication, okay, or an avenue of investigation. So, do listen to the chief complaints. One of the things that's said is doctors don't listen, okay, and it also assures that the patient you're going to address what their concerns are. Okay, you're starting to build patient confidence. Pregnancy, birth, you want to know if mom was exposed to toxins, microbes, immunizations during pregnancy, what was the mom's general health, were there any problems during the pregnancy, how do you know? Ask the patient. Say, hey, listen, when your mom was pregnant with you, did she tell you any stories about her pregnancy with you? Trust me, if there were stories, they would have been told. Okay, how about your birth? Tell me about your birth. Did mom tell you that there was any difficulties during your birth? Were you a C-section? Did they have to get the salad spoon and drag you out? Moms talk about these things, okay? Were you taken to the neonatal intensive care unit? Were you quiet? Were you, very active and so forth? Let them describe the baby, Okay, a lot of times you'll have a lot of hypoxia that doesn't come out as cerebral palsy. There's this point where there's damage to the brain, but not as much damage. And what I end up seeing is a lot of anxiety disorder, okay? And those APGAR scores, by the way, ignore them. Everybody lies. Everybody lies. So you want to ask me, what kind of baby were you? You know, or if you're talking about a kid, what kind of baby was a baby? A good baby is a very ubiquitous term. Everybody in the world uses the same term. It means you fed well, you slept well, you pooped well, great. But if you were a fussy baby, did you have colic? Were you squirmy? When did it start? What brought the symptoms down? What made the symptoms worse? Did the baby dislike clothes? You know, how many babies you have that just don't like clothes? It just makes them feel horrible. Okay, and when they start walking, they'll whip off their clothes in a heartbeat. Okay, so the baby has trouble sleeping. Its slightest sounds wake babies up. These are all indications of extreme neural excitation. You've got to follow it up. Developmental milestones, okay, you should ask, you don't necessarily have to ask specifically, but were they early, were they late, did the baby crawl? If the baby stood immediately, especially started running on their toes, but didn't crawl, that's primary neurologic disorganization. You need to crawl for a while, and quite a while, okay, in order to organize your nervous system, because 98% of the fibers decussate to the other side. And the way that we practice that is with that cross-crawl motion. And any of you wonderful women out there that have had babies, okay, you know that once they get the idea, they move like, like have a motor in them. Okay, because once they get it, it's good, all right? And of course, if there was any interruptions and that kind of stuff, we need to know. All right, immunizations, you want to know when they got immunizations, you know, if they got them in the hospital. There's just a whole immunization schedule. It's different in each country. I found out in Poland, a lot of my autistic children became autistic because at 4 hours of age, they were given 2 immunizations, one for TB and one for hepatitis, I think. And those who were susceptible started right then. You want to ask about early childhood. Were they social? Were they shy? Were they painfully shy? Were they studying perpetual motion? You also want to listen for changes. Like, wow, she was really active, but at some point, she became very shy and very withdrawn. Something happened. Grade school, you know, and I ask the patients like this all the time, looking back with your present knowledge, and you look at that little boy or girl, would you say that they had ADD, ADHD, OCD, difficulty in focusing, clumsiness? Were you bullied? They'll tell you. Okay, they'll look back at that child and tell you. Being a teenager, oh my gosh. Okay, a lot of things happen when you know the hormonal changes go on. So always remember that is an immense area of stress and strain and a lot of exploring. And let's face it, the prefrontal cortex is not formed. So that's why teenagers act like teenagers. But they're also under a lot of pressure, and there also can be a lot of predators out there. That's where you get the hyper-religiosity, people joining cults. They do it with teenagers, okay? So listen for things like what changes happen upon menarche, okay? Were the changes that happens like isolation, moodiness, drug use, alcohol use, change in friends? Was it worsening of prior conditions? Just think that this may be an expression of genetic predisposition, okay? And trauma or long-term effects of root causes can be exacerbated by the hormonal changes. And that's why in schizophrenia, okay, the common time when that becomes apparent is 14, 15, 16. Before that, the hallucinations were those friends that they were talking to. Hormonally, the friends start turning mean and start yelling. So I want you to listen to this real close. As it says in Matthew 13:9, he who has ears, let him hear. As the patient's relating their story, I want you to think about trauma all the time. Listen for indicators of physical, emotional, or sexual trauma. Things like repeated UTIs or vaginal infections in small children. Significant deviation from the baseline, like an energetic child becoming shy. Nightmares, insomnia, sudden onset OCD, behavioral changes at any age that are sudden and can't be explained as age appropriate, and if they cannot remember part of their childhood. That's a biggie. So listen, you might want to gently ask about trauma. One of the ways I ask about is very, very non-committally is, you know, have you had any trauma like head injuries, um, you know, physical trauma, bullying, sexual trauma, anything like that? Engage the person's reaction. If they look big, and especially if it's sexual trauma, you've opened the door, and I just look at them and say, wait, I don't want you to relive it. You don't need to tell me that. I just need to know if it happened or not. Okay? And you want to close that door because you don't want to open Pandora's box unless you are, in fact, capable and trained in dealing with this. So what I usually suggest is that you assess the patient support system. If they receive counseling, do they have an available counselor? If they don't, you might want to suggest that they seek out somebody, and you should have referral sources just in case. And this is the way I play to them. You know, as you're healing, things may come up. You know, and I'd like you to have somebody to talk to who's trained to help you deal with it. You may get cooperation, you may not, but at least you've dropped the seed. Adulthood, all the stuff you do for adulthood, and remember, all the while you're developing a therapeutic touch with a therapeutic trust with the patient. The trust you build will allow them to create an accurate assessment, and they'll comply with your treatment plan. Plus, you are empowering them. When you're teaching them, you're empowering them. You empower them. They get confidence in you, and guess what? They start to heal. And you're also going to avoid this particular pitfall. Dr. Google. Oh my God. I can't tell you the amount of patients come in and say, this doctor said this, and this doctor said that, and this doctor said this. I'm like, and sometimes when I'm not in a great mood, because I'm Italian, you know, I'll look at them and say, do you have any idea what you're talking about? Just any idea whatsoever? You know, because they don't. But most of the times I say, look, you know, I respect everybody's opinion, but this is the way we're going to work, and I want you to follow along with me for a little bit. But patients will, you know, pit one person against another, and after a while, you have to look at them and say, look, you know, a doctor who treats himself has got a fool for a patient. That goes for patients also. So again, maybe it's not the best of ideas for you to be treating yourself, and that's why you've consulted me. Okay, and you don't have to be aggressive or assertive. There's a difference between aggression and assertion. You may need to be a little assertive. Otherwise, if that person's just going to be researching all the time, it can really get in the way. Okay, this is when you should review studies. Not at the beginning. You don't walk in with a test and say, your tests say this. No, you listen to the patient first, okay? And that's when you circle back to the treatments that were offered, what helped, what didn't help. And I want you to get the idea of learning to follow crumbs. Because when you've eliminated the impossible, whatever remains, however improbable, must be the truth. So I want to give you a little bit about breast implant illness while we're here. This is Danielle Valeris. You're going to be hearing a lot more from her. She's a beautiful young woman who lives in North Carolina in the States. She is a researcher, a trained physician's assistant, and she just spoke in front of our FDA about breast implant illness, which is amazing. Anyway, as early as 1997, we've known that silicone and other things can cause difficulties. And in this particular case, 32-year-old woman, which I love the way this is written. A case reports of a systemic near fatal illness possibly related to augmentation mammoplasty with silicone gel prosthesis. Okay, here's for the 24 hours after implantation. The woman develops high fever followed by diffuse arthritis, renal failure, and bilateral pulmonary infiltrates. Shortly after the removal of the prostheses, the patient's condition improved dramatically. Samples from blood, urine, sputum, and breast pockets collected at the time of the prosthesis removal demonstrated silicone polymers, but evidence presented that indicate the illness was not of infectious origin. So the only thing they found was the silicone polymers, and it's possibly related to the augmentation procedure. I love the medical profession. Okay. This is interesting if you want to read all about Dr. Edelson's work, but you'll notice that the symptoms here, peripheral neuropathy, central neurotoxic neuropathy, cervical and axillary enlarged lymph nodes, and then fatigue, malaise, weight loss, joint tendon pain, da 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 da. Sounds like inflammation to me. Okay, this is what's in the implants. Even if you have a saline implant, this is in the shell. Look at all the various substances. Lead-based solder. What are they soldering? I don't know. Printing ink, color and pigments as release agents, ocalite, cleaning solvent. This is all the stuff that's in the shell as well as the silicone. So guess what? There's something called autoimmune inflammatory syndrome produced by adjuvants. It's called Asia. And there's been loads of evidence of silicone-related illnesses. And what the bottom line is that the breast implants will degrade at about 6 to 8 years. Why would they degrade? Why would they break apart if the immune system's not beaten up on it for a long time? And don't forget where it sits, right next to the heart and lungs. Okay, and here are the symptoms of breast implant illness. Okay, need I say more? Anxiety, fatigue, joint pain, insomnia, brain fog, candida, yada, 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 yada. Sounds like chronic inflammation to me. Now, here's a patient, okay, before and after. The before, you can see the breast implants because they're cold, okay, but you can also see in the axilla and in the neck the redness, which is the lymphatic flow, okay, which will give you the reason for the enlarged lymph nodes. And this looks like about a month later after explantation. Look at how cool those areas are, okay? And these are what the implants look like. This is disgusting, but it's true. These are other implants, and this happens to be Danielle's. I do have permission to speak of her. Danielle's implants that were undetected by, the rupture was undetected by MRI, ultrasounds, and 3 plastic surgeons. And she had symptoms of ruptures, all the other stuff, but over 50 medical professionals did not make the connection except me. Okay, let's do a couple of clinical studies. Do we have time? Yes, we do. Okay. So I have a couple of clinical studies here that put together a few things, okay? This is a tale of mom and 2 kids. This is a 35-year-old female who came to me with mood swings, chronic fatigue, throat pain, joint pain, cognitive decline, dizzy headaches, difficulty emptying her bladder, low libido, craving for sugars, appetite, insatiable appetite, and she was pretty good, except she took Accutane as a teenager. And after college, she developed exhaustion, insomnia, some cognitive problems. Everything got worse after children. She started developing enlarged lymph nodes, stomach problems, throat pain, hormonal issues, sugar cravings, progressive worsening globally over time. Then she asked me to look on, this is her testing. The neurotransmitter tests look like an immune problem with advanced decompensation. The cortisol curve looks nice, but it's all in the bottom. With this, norepinephrine being like this is stage 3 adrenal fatigue. The Lyme tests were negative according to the computer, and with the next case I'm going to show you why that would have been considered positive. Okay? Then she asked me to look at her daughter, who was a full-term baby, gained weight quickly, started getting rashes, started getting blood in her stool that the pediatrician said she was too young for that. And I'm like, there it is, blood in the stool. Oh, no, she's too young for that. There it is, blood in the stool. She's too young for that. There it is, blood in the stool. She's too young for that. Okay. She was breastfed, but she reacted to mom's food choices, and mom did a elimination diet, and the baby did well. That was a red flag to me that the baby's reacting to breast milk. And when she was placed on regular food, unless it was all made by mom, she would have symptoms. So she already had food intolerances. At 2.5 years old, she started strep infections with high fevers. There was extensive antibiotic use. She developed obstructive sleep apnea from large tonsils. The preschool teachers said that she zoned out. And then she develops anemia, body aches, low iron, and jaundice. And takes iron, nothing was helping, and the doctors were unconcerned. Oh my gosh. Now she asked me to look at a 3-year-old. normal pregnancy. After coming home from the hospital, started getting a rash on his face, rash on his bottom, starting having tremors and severe sweating while feeding. That doesn't tell you dysautonomia and nothing wrong. He needed to pry his legs apart to change his diapers. Nasty nasal congestion, episodes of cyanosis that they diagnosed as GERD, which is GI nonsense, episodes of black tarry stools, and was found to be severely anemic, but of course the endoscopy and colonoscopy were negative. Hit all the milestones on time, coordination and balance problems, had vitamin mineral malabsorption, drank a lot of water, bruised very easily, reacted to all of his immunization, wakes up several times a night and is unable to settle himself, bouts of very high fever, anxious, nervous, and now his back and arms ache. Back, neck, and arms ache. Well, this was too weird for me. So I re-interviewed the mom, and I said, listen, if there's anything you haven't told me, please tell me now. And she said that the father was estranged and he was taking Suboxone. That's a medication the state's used for heroin addicts. That's exactly what was going on. He was a heroin addict. And I asked the appropriate questions. I said, look, did he use needles? Oh, no, he never used needles. And I said, he was a heroin addict. Did he engage in risky behaviors and so forth? No, I don't believe that he did. And then I started questioning her some more, and she began to really doubt. This was in her mind. She was just denying it. Where he got infections that he said was from a work injury. And I said, listen, we have to be more concerned about our children. Notice, we have to be more concerned about our children than about ourselves. Would you agree? She said, yeah. I said, perinatal Lyme is one consideration. Yeast is another. But you know that we have to check for HIV because of needles and so forth. And I said, listen, let me have you tested privately, and then, because I'm thinking advanced immunocompromise. Well, that's exactly what happened. Okay, she did have HIV. So did the children. I understand they treated with another specialist, but I understand they're doing very well, and they're living better lives. But this was all in history. But listening and saying, boy, that's too weird. The next case, and this is our last one, is Alyssa, who is an 8-year-old female with visual distortions. And her mom contacted me because she thought she needed Erlen glasses, which is a set of glasses for scotopic sensitivity syndrome. She also had a bad gut upon eating anything. And after questioning, and then I had her check with the baby, that she had auditory, olfactory, and visual hallucinations. Well, let me tell you something. Olfactory hallucinations are a brain tumor unless proven otherwise. Olfactory hallucinations are a brain tumor until proven otherwise. So she went for the standard medical workup. I told her, come back if they found everything negative, which they did. So I said, let's look around, right? These were her pathways. Okay, this is an earlier version of strategy when it was in development. And we noticed that she had difficulty breaking down her catecholamines also. She had difficulty converting glutamate to GABA. Here's an article for you. By the way, the medical profession still does not believe that neurotransmitter imbalances cause mood disorders. I don't know where they don't get it, but here it is. Okay, difficulties in metabolizing organophosphates from the PON1 and the SODs, which is reactive oxygen species, that's peroxide dismutase, and yeast from the aldehydes and the acetylation pathway. Okay, BHMT, should you see it like this, I know it's a sideways pathway to get homocysteine, but when you see it this bad, this person is going to internalize their stress and have chronic dysthymia, which is a low-level depression. Also, if they have a traumatic event that leads to post-traumatic stress disorder, they will respond better to EMDR type therapy, desensitization therapy, than they will to talk therapy. Her transsulfuration pathway didn't look so bad. But there was a lot of indicators that she would have difficulty with B12, that she produced a lot of immunoglobulins upon leaky gut syndrome, and her methylation pathway looked a little funky. Now, most most applications out there will show you two MTHFRs, usually the C677T and the 1298C. Some of them will give you 15. And think about it this way. Think about all the MTHFRs, which is, there are about 50 variants, talking about the function of the enzyme. So if you had 50 variants, or let's say 15 here, and you only had one polymorphism, how much is the overall enzymatic effect going to be interfered with? Not much. But when you have a lot of them like this, the enzymatic effect is going to be significant. And I will tell you a little secret clinically, that when you see this many MTHFRs, you may have at one point in their life a suicidal person on your hands. Okay? And remember I talked about the high levels of GSSG having difficulty going into the mitochondrial first complex of the mitochondria? Well, NDUFS is the enzyme that runs this. And if we don't have an 8-lane highway, if we have, let's say, we'll call this a 3-lane highway, okay, and you're having high GSSG, you're going to really interfere with your mitochondrial function. This is a chart that I made up for you guys that shows you symptoms and complaints, what the SNPs might be, involved, what your index of suspicion for being for root causes, what the downstream effects would be, what questions to ask what questions to ask, and what testing to do. Okay, I'll give it to you for what it's worth. Okay, so I know she had leaky gut. I know she has neurotransmitter imbalance, aldehyde metabolism, methylation, and mitochondrial dysfunction. So what we needed to do is correlate everything. And the process of diagnosis is finding out the root cause of the condition. OCD is not a diagnosis. ME is not a diagnosis. CFS is not a diagnosis. Fibromyalgia is not a diagnosis. Unless you can tell me why something's happening, that's not a diagnosis. So remember that it may be a capital mistake to theorize before one has data, but the reason for that is insensibly one begins to twist facts to suit theories instead of theories to suit facts. In medicine today, we have a bunch of diagnoses, even though they're not diagnoses, and we have to put somebody into those slots. Otherwise, we don't know what to do. So we have to twist them to satisfy our theories. And on the other hand, what we should be doing is twisting our knowledge to heal that person's individual pathophysiology. So this is listed as neurotransmitters, okay? And you see that the glutamate is high, dopamine is high, and norepinephrine is high. And this is what you'd expect, especially high dopamine in somebody who has psychosis. Okay, and I can tell you about the pattern here. Okay, look at the norepinephrine pattern, okay, and the lower serotonin and GABA, that this is an immune problem with mid-level decompensation. So something's been causing this. So we need to know who's been upregulating the nervous system, and we've got to think about leaky gut syndrome. Will that do that? Absolutely. Okay, will microbes do that? You know that they will. Okay, these are all the symptoms, in case you're wondering, for Lyme disease. Okay, so this is what Alyssa's actual Western blot looked like. Now, let me tell you the criteria for positivity. This is why just looking at positive and negative on a computer printout is no good. All right, what we actually do is this would be Alyssa, and the band locator or the exemplar band would be somebody with Lyme disease. And the criteria for positivity is that the intensity of the person, the patient, has to be 60% or more of the exemplar band. And this particular company, which is MDL Labs in the United States and New Jersey, actually measures it. So here you see on the 93, you see 96, then 120, 36. So 45 won't be reported, 40, 76, 58. So 39 won't be reported, 120, 93, and 60. Now, this will give you enough for a positive test. But think about it. Let's say this was 58, 58, 58, 58, 58, 40, 40, 58. It would report nothing positive. Yet, you have to ask yourself the question, if I am producing antibodies for Borrelia burgdorferi, even though they don't hit the CDC criteria, why am I doing that if the bug's not there? So this is a positive test, and don't be fooled by this IgG and IgM stuff. IgM may be more recent. IgG may be a little bit in the past, but it's not years in the past. IgM rises and falls quickly. IgG rises slowly and falls slowly. Okay, so we're going to take this and take the 45. I would say that the IgM rose and went down already, and these are on their way up or on their way down, but they're still pretty high. We did other testing. We found that she had a candida, HHV6, which is a herpes in the brain, and numerous food allergies. So we know we have Lyme disease. We know we have yeast overgrowth. We know we have leaky gut syndrome. We know we have a viral syndrome. So I always stop and I say to myself, can leaky gut lead to immune upregulation, dysregulation that is evidenced by the numerous food allergies and causing the patient's GI symptoms, and can that cause an increase in catecholamine and hallucinations? And I say, yeah. Can Lyme and HHV6 attack the neural cells? Mm-hmm. Can yeast overgrowth cause increased levels of acetaldehyde combined with difficulty in breaking that down because of the NAT2 or the ADLH SNPs? Can that cause neural inflammation resulting in hallucinations? Any one of these can. All three makes it pretty nasty. So what did I do? What you want to do is decrease the traffic. Do that by fixing the gut. At the time, this was several years ago. Okay, so I put her on the basic gluten-casing, soy-free diet. I used emulsifying herbs to increase the mucus layer, phospholipids to support cellular repair, digestive enzymes to ensure full breakdown of foods and prevent the creation of antigens. I gave her a DAO enzyme because I felt that she had histamine issues also, and I use a salt-based probiotic with Saccharomyces boulardii to pull the yeast off. Now, at the time, I was working with an integrative pediatrician, and we got to the point where we wanted to start treating the bugs, and the pediatrician wanted to put a PICC line in her and use IV rotating antibiotics. And I looked for another option, which was another substance that I presented to the parents that I noted was a broad biocidal agent, but I thought was very safe. They decided to do that first. And 6 weeks after I started that, all of her symptoms were gone. And 3 months after I started that, I retested and everything was gone. Okay. The sleuthing is worth it because here's my Alyssa. She was 8 years old here, looking at a life on antipsychotic meds. And in reality, her hallucinations were an expression of genetic predisposition caused by neural excitation and immune upregulation, secondary to infections and leaky gut syndrome, all kept going by chronic cell danger response. And here's Alyssa at 12, and here's Alyssa at 15. And tell me that she is not a beautiful young woman. This would have been a disabled individual. This is a contributing member to society and just able to live her life. So you think this is like too much, overwhelmed? Don't worry about it. We're medical detectives. Use the information that you have in front of you. Correlate history, polymorphisms, pathway guidance, clinical observation. Look at the tests, interpret them in light of your other information, and never blindly follow a protocol. Okay, because protocols were made for lazy people, really. It's nice to have them because you know what does what, but the difference between Cowden and Byron White and the use of biocidin, you need to be able to know what they all do so that you can mix and match and pick it out for your patients. And you need to embrace, when you have eliminated the impossible, whatever's left, however improbable, must be the truth. And be the master clinician. Treat the previously untreatable. Let this be said of you. I don't know if you can hear this, but this is from The Princess Bride. Okay, and it says, this is when they were meeting. Okay, and it said, sorry. Vizzini says, the masked man says to Vizzini, says, "You're that smart?" And Vizzini says, "You've heard of Plato, Aristotle, Socrates?" The masked man says, "Yes." Vizzini says, "Morons." It's pretty funny when I'm doing it on stage. Okay. So if you're ready to pick up the gauntlet, and heal those who suffer in silence. I'll walk with you. Because my son Jesse is a scientist, he's a graphic artist. He was published as an undergraduate. He was published in scientific peer-reviewed journals. Okay, he was an Eagle Scout, which is the equivalent of your Queen Scout, and he was a Nature Lodge director for 6 years at a Boy Scout camp. And he has his own business. And in fact, the brain wall is his creation. Alyssa is an honor student. She's an athlete, and she's a beautiful young woman. We are the people who are going to heal people. We are the professionals that are going to heal people. We simply need to know, are you willing to pick up the gauntlet? Are you willing to advocate for your patients? Are you willing to take a few hits like a good boxer? And are you willing to heal those who suffer in silence? Okay, so I'm going to stop sharing. If there's anybody left, oh, good. Okay. I'm happy to take your questions. And I've unmuted everybody. So if anybody has questions, I'm happy to answer them. Or did I lose everybody? Which wouldn't be too unusual for me.
Hi, yeah, I've got a question. If you can
Rebecca?
hear me. Yeah. Yeah, can you hear me okay?
I see you're talking, but I can't hear you.
Okay.
Talk again, please. It's telling me to cut out resources. So I'm doing that right now. See if that helps. The effect of the green tea on the Foley pathway is to interfere with the, I think it's the DHFR. Okay, it's not a big effect, and it only really should be considered if somebody lives on green tea and they have a folate problem. The vast majority of the folate problems is having usable folate, which is natural, green vegetables and so forth, leafy green vegetables, and NAD to run it through. Unless somebody lives, like I said, for green tea, if they're having a couple of cups a day, it's not going to be a big deal. Anybody wants to ask questions and they can't, they can use the chat. Excuse the chat function here. Okay, just on the bottom of your screen. Okay, and I'm trying to cut out different things that are maybe affecting my the performance here. Okay. Amy, do you have any questions or anybody? Just type them into the bottom, okay? And I'm happy to answer them. I usually come to UK every few months, and next time I'm going to make sure I get up to Edinburgh. Maybe I'm going to start there on my way down. This was just a little too up and down for me. And, I'll make sure everybody gets this. You're going to get this plus the, the brain wall, and I made 2 videos. One to teach you how to read the brain wall, and one that you can use for your patients. Okay. And so I hope you like this stuff. Okay. Alrighty. Thank you. Since there's no, you're most welcome. Thank you very much. I will give this all to who the representatives are, and they will, I don't know what they'll do, but I'll make sure you get everything. Okay. All right. Take care.
Thank you.
Bye-bye.